So yeah, I can make a start, guys, if it's a good.
Yeah,
if
please.
everyone else is ready, no problem. Okay.
Thanks.
So a few weeks ago, when I was presenting a case, I started showing you some functional analysis, and probably ran through that rather quickly. So there were some requests to maybe go through that specifically, and to show some of the different types of analysis we can do, particularly using Speckle tracking. So I was just going to spend maybe 20-25 minutes this morning showing you that, if that's helpful. And until anyone tells me otherwise, I'll keep talking. So I'm gonna start by sharing my screen here and showing some PowerPoints. Nice to see you all here today. Let me check I've got the right one. Yeah, this is good. Okay, hopefully you can all see that. Let's put it on here. So the starting point for this that I find useful is to start to think about why fundamentally are we looking at different aspects of ventricular function, and how do the ventricles function in particular? What's their dynamics at the level of the combined muscle fibers and the gross kind of change in chamber size over cardiac cycles and change in morphology over each cardiac cycle. We all kind of learn functional analysis kind of using what are well-established measures, but each of them is really just looking often at a very small part of one ventricle. So for example, the way that we calculate fractional shortening or ejection fraction using an M mode through a cross-section of the left ventricle is really only looking at one very specific point and one very specific direction of chamber change in chamber size and myocardial thickness. The same goes for tissue Doppler. That's only looking at a small part of the myocardium in the basal region. Same goes for TAPSE. That's only looking at the displacement of one part of the ventricle in a 2D plane. And what I think can be useful is actually take a step back and say, what's the global function of these ventricles, and how can we get a better picture of that? So I'm just going to spend a couple of minutes just to think about that global function of the ventricles. And this first slide is just to illustrate from this schematic diagram the relationship between the right ventricle and the left ventricle and their relative shapes. The left ventricle is almost easier to get our heads round, because certainly, as you see on the panel on the left-hand side, it's a relatively symmetrical structure, which has certainly from the bottom third downwards, this kind of cone shape tapering to the apex, and relative symmetry to that structure. If we look in cross section, as you know, it's generally circular in cross section from the base to the apex. So that describes that symmetry of the ventricle. The right ventricle is a whole other world, because as you see here, it's this. In some directions, it's more of a triangular shaped structure. It, to some extent, applies itself and wraps itself to the anterior wall of the left ventricle. And it's not symmetrical in its structure. And when we look at the nature of the change in chamber size and morphology during each contraction and relaxation, that's determined by the orientation of the muscle fibers. And of course, the muscle fibers are shared. They wrap around the right ventricle and the left ventricle through the septum. So there isn't this idea of separate muscle fibers in each ventricle. In some ways, you know, we call them a separate right and left ventricle, but morphologically, that they're one single structure made up of the same fibers, but with this a wall that divides the single structure into two. And the fibers themselves, as you know, form different layers, endocardial, mid, and then epicardial layers. And the orientation of the fibers is different in those layers as well, as is represented in the kind of simplistically in the panels here. So endocardial fibers, especially in the left ventricle, and well, very much in the right ventricle as well, tend to be more longitudinally positioned in terms of their displacement. So when they shorten and lengthen, they're doing it in the longitudinal plane, as you see represented in the bottom left panel. So when they contract, the ventricle is going to get shorter. When they relax, it's going to get longer. And in the right ventricle, as we know, longitudinal function is a really important component of right ventricular function, more so than in the left. And that's possibly why things like TAPSE and longitudinal tissue Doppler measures, and arguably longitudinal strain, are probably the most useful techniques to assess function in the right ventricle. Then there's the mid fibers, which have more of this circumferential pattern. And when they contract, when you look in cross section in that ventricle, as you see in the middle bottom panel here, they're going to cause circumferential shortening, which means that the donut, if you like, is going to get smaller. The hole in the donut is going to get smaller. And what they also cause is radial shortening. So, and it's actually radial thickening during systole. So the donut gets wider, the hole gets smaller, but the donut itself gets wider. And then, there's the epicardial fibers, which contribute as much to the circumferential shortening as well. They're the ones that are shown here, wrapping it kind of at an angle around the ventricle, and they contribute to the donut getting overall smaller, and therefore the hole in it getting smaller as well. And as we said, the orientation and direction of fibers is different between the two ventricles. In this representation of the right ventricle, there's very important contribution from those endocardial longitudinal fibers in the right ventricle, contributing to the shortening as a dominant component of right ventricular contraction. But there's also the circumferential fibers in the right ventricle. It's not a donut, remember, that ventricle. It's more of a kind of wedge that is beside the left ventricle. So when those circumferential fibers contract in the right ventricle, they don't so much cause that narrowing of the donut that you see in the left ventricle. Instead, they cause more of a bellows action, so a squashing of the right ventricle up against the left ventricle. And because of the overall morphology of the right ventricle, as I showed you in that first picture, it's actually really hard in 3 dimensions to get a full sense of that longitudinal and circumferential contraction of the right ventricle and that bellows action that it makes. The left ventricle is actually easier because of its symmetry. This picture, again, just shows some of the orientation of those different layers of muscle fibers, the longitudinal ones, the circumferential ones, and the epicardial ones that are more radial. But what it also shows is that the direction of some of the muscle fibers is actually different. And some of the fibers form a right-handed helix, and some of them form a left-handed helix. And that means that when those helical ones contract, some of them will cause rotation in one direction, and some will cause rotation in the other. And in the left ventricle, in the mature left ventricle, typically the rotation at the base, at the top of the ventricle, is counterclockwise, and at the apex is clockwise. So they're going in opposite directions. And that's what creates what's shown in the figure here, this kind of wringing out action of the ventricle. So it's like wringing out a towel to get water out of it. And it's estimated that twisting or wringing of the ventricle generates up to 60% of its contractile function and the ejection function of the ventricle. So it's really important, but it's not something that we talk about in our normal assessment of function, is it? You know, we don't have in common usage a measure of that twist or that rotational function of the ventricle. So, sorry, this figure is just to demonstrate that as well. If you look at panel B at the top, it's showing that in red that basal counterclockwise rotation of the muscle fibers in the circumferential plane, and in the apex in the circumferential plane rather, the clockwise rotation. And if you look at the graph at the bottom, what it's plotting there on the y-axis is the size of that rotation in degrees. So represented in red is the basal rotation, and you can see what actually happens is in early systole, there's a clockwise rotation, so that's shown in panel A, of those basal fibers, but then later and for more prolonged period during later systole, it reverses and it becomes counterclockwise. And it's at that point that you get the greatest difference in the rotation between the apex and the base. And that is what's called the twist. So it's the difference between the peak apical rotation and the peak basal rotation is the twist. And if you look at that graph, you can see that the difference is greatest when the basal rotation is negative, i.e. counterclockwise, and the apical rotation is clockwise and positive. And therefore, when what we do is we subtract the basal rotation from the apical rotation. So you're subtracting a negative number, and that's why the overall rotation is even more positive. Does that make sense, guys? So it's the difference between the two, bearing in mind that they're in opposite directions. So the magnitude of difference is actually the sum of the absolute numbers of the rotation at each level. Thanks, Mahmood, you give me the thumbs up, so hopefully everyone's still with me. So what I was going to then talk a little bit about is how can we look at those different aspects of function, and particularly thinking about how we use Speckle tracking echocardiography. So in my simple understanding of Speckle, what Speckle is basically software analysis. And it's analysis of the speckles that we see on 2D ultrasound. And of course, those speckles simply represent the effect of outgoing ultrasound waves and reflected ultrasound waves interacting. So where they interact in phase, you'll get bright echogenic areas, and where they meet out of phase and they counter each other, you'll get black areas. And the software is simply looking at those speckles, those bright areas of high echo intensity, and looking at the relative movement of those during each cardiac cycle. And we interpret the movement of those speckles as displacement or strain. That's what strain is. So in systole, if two speckles get closer together, then that's a negative strain, a shortening of their separation or displacement. And if they get further apart, that's a positive strain or positive displacement. And we interpret that as a proxy measure of the relative movement or change in dimension, rather, of the myocardial fibers. And the beauty of Speckle tracking echocardiography is that if we've taken the correct views, we can start to look at that relative shortening or lengthening in those planes that coincide with the muscle fibers within the ventricles, and therefore within their planes of normal contraction and elongation. So as you see represented here, typically in the apical 4-chamber view, we use Speckle tracking to look at the longitudinal function. This is in the left ventricle, looking at longitudinal strain, and the software divides the region of interest, the ROI, into 6 segments, typically 3 septal segments and 3 free wall segments. I'll come and show you that in a second. In a circumferential plane, so we're obtaining this from a short axis 2D view, and we can do that at the level of the base of the heart, or mid-ventricle at the level of the papillary muscles, or at the apex. Then we can use that to look at 2 things. The first is the circumferential strain. So remember, that's the narrowing of the donut. The donut's getting smaller, and the hole inside it is getting smaller. So because it's a shortening in systole, it's a negative strain, like longitudinal strain. But in that plane, we can also look at the radial strain. So that's looking at the displacement within the myocardial wall in the plane that you're seeing represented in the schematic there. And that should normally be a thickening or increasing radial strain during systole, representing myocardial thickening during systole. And that therefore is a positive strain represented in the strain curves that you see in the bottom panel there. So let me show you that in real life, in an echo on a patient, to show you how we actually get those curves. But I just, while I'm doing that, just open up for any thoughts or questions, and anything that needs clarified from what I've said so far. Go for it, guys. I'm just going to switch over and hopefully share this echo with you as well. Any questions, thoughts so far?
Neil?
Yeah.
You said that if they are distancing from each other,
yeah,
they are negative. Is that correct?
Sorry, say that. Sorry, so I just missed that.
When the particles distancing from each other,
yeah,
correct, they are negative.
No, if they're getting if they're getting further apart, that's a lengthening, and that's a positive strain. If they're getting closer together, then that's a shortening and a negative strain.
Got it. Yeah. So the last graph yet you said, if they are squeezing to each other, so they're getting closer to each other, that's why they are positive.
Yeah,
okay.
yeah, I'll just explain that one again, because I agree that needs a little bit of just thought. So it's something that in systole, in the circumferential or short axis plane, the myocardium is thickening. So the diameter of the ventricle in this space here in the middle of the donut is getting smaller, and part of the contribution to that is a thickening of the myocardium in systole. So that's why when you look in that plane at strain within the ventricular wall in the radial plane, it's actually a lengthening, which is a positive value during systole. Whereas when you look in the circumferential plane and the longitudinal plane, because during systole there's a shortening, that's a negative strain. Does that make sense? It's not something we're always used to thinking about. We always think about systole and contraction, about muscle fibers getting shorter. But actually in the radial plane, they're getting the myocardium is thickening during that systolic phase, and that's what gives a positive or lengthening, a positive strain or lengthening during systole.
Okay, one more question, Neil. I'm sorry, I'm just slow to accept. When you're looking for among the pieces of the of the spectacles, are they in the different walls of the ventricle, or are within the wall?
They're within the wall. So it's looking at the speckle of the myocardium within the ventricular wall. Yeah, I'm going to show you in a second just how we do it, and you'll see there which regions of the myocardium it's using to measure strain in. No problem. Mark, you've got your hand up, and I know you're an expert on all of this as well.
Yeah, just no expert. Just wanted to check if I'm understanding correctly, Neil. So these are still local markers, though, right? They're associated with global function. Am I right?
That's right. Yeah, good point. So what we're looking at, what the software is looking at regions of interest, and they're quite sizable regions. I'll show you on EchoPack.
Okay.
Because it's harder to show on this slide here, because the pictures I've got here are quite small. But what it then does is it averages those, and we use that to report a global strain as an average of these 6 segments that we typically look at. And that in itself is quite important to take on board as well. So, because as always, we want to simplify everything down to a single number. And typically using Speckle tracking, we report a single strain number. But what you have to realize is that even that is an average of many segments, and each segment is averaging quite a substantial part of the myocardium. I'll show you how we do it, and then hopefully you get a better feel for that.
Thanks.
Okay, so I'm just going to switch over. Okay, guys, hopefully you can see. You can. Good, I can see that on the other one. Right. This is actually the baby that we discussed a few weeks ago. So I'm just going to use their echo because it's one that's of interest, I suppose, and useful. So the clinical background is not so important. We're not really going to be discussing that just now. But it as a reminder, this was a baby with, in the first day of life, turned out to have severe sepsis. Came to us as query PPHN kind of phenotype, but actually turned out to be a baby who had quite significantly low SVR and needed quite a lot of vasoconstriction. But we can come back to that if it's of interest. This is an apical view. Apologies, I still tend to look at these as an inverted image. I can turn that up the other way for you all. So slightly dilated right ventricle here. Now, I suppose an important point is interpretation of function from 2D loops. And although it is subjective, it is arguably a standard of functional assessment. If you ask the cardiologists to come and assess a baby, they will predominantly, historically, base their functional assessment on their experienced expert interpretation of the 2D images. And although that has its limitations, although it's subjective, it's not quantitative, it still has merit, because although we use a lot of complex software to do the functional analysis on these echoes, I would argue that the brain of each of you is also a very complex piece of software, and that with experience you actually are pretty good at interpreting function from a 2D loop. What becomes harder to infer, I think, sometimes is regional function and separating diastolic function. I think that's quite difficult just looking at a 2D loop. And of course, we're also not looking at that three-dimensional function of that ventricle just on a 2D loop like this. But I suppose the point I'm making is, don't discount the ability of an experienced echocardiographer to look at a 2D image and to infer what is happening with the function, particularly if you have a sort of systematic approach of looking at the apex and then looking at the base, of comparing free wall and septal function in each ventricle. Anyway, clearly it's even better when we can add a level of quantitative objective analysis, and that's what I'm going to specifically show you with speckle tracking. So let's start with the left ventricle in the longitudinal and longitudinal plane. I'm going to look at it in the inverted image just because that's what I'm used to doing. Now, in terms of image optimization for doing speckle tracking, you want to have a nice loop that includes the whole of the ventricle that you're looking at, so the whole of the free well and the septum, and ideally the apex. The left ventricle could be tricky. As you're seeing here, we're getting a little bit of probably a bit of lung artifact or lung ultrasound rather, in just coming into the apex there at the end of systole, and that may affect our ability to optimize the analysis here. So I always, when I'm collecting images for functional analysis, usually take a couple of loops, and I'm just conscious of trying to make sure I've got complete views of the ventricle I want to look at. You don't have to have views that incorporate both the left and the right ventricle together. I'll often take a left focused view and then a separate right focused view and record those separately as loops for analysis. But we'll use this one. It's slightly suboptimal, but that in itself is perhaps part of the learning on the analysis. So on EchoPack here, what we do is we select Q analysis. That's the software package within EchoPack that allows us to do speckle tracking. And we want to look at 2D strain. It then asks us which view we're looking at. This is a 4-chamber view, so I'll click on that. So now what it's asking us to do is to create a map of that ventricle for it to then start to look at the speckles within those regions of interest. So first of all, it wants me to choose the basal septum. I'm going to choose there. And then from there, it wants me just to map out the ventricle. So I'm just broadly mapping it out by plotting these little dots around the ventricle. I'm not sure if that's going to be right. I'm trying to do it on the kind of inner wall. I don't want to pick up too much papillary muscle. The apex is perhaps a little bit hard to take in there, but I'll choose that as a region of interest and see what it thinks of. So once I've clicked on that, it then kind of, as you see, superimposes this map with the regions of interest in the septum and the free wall. What I can now do at this point is just adjust my points. I think this one's too far out. I'm going to bring that in, and this one as well. The apex is looking a bit kind of abnormally pointy and not quite in. That's right. This one might be a little bit far out. But let's see, I'm just going to leave it there for the moment. The other thing is that you can adjust the width of the region of interest if it looks like it's too broad. It might be a little bit. I might be going out into epicardium here in the free wall. So I'm just going to narrow that down a little bit and we'll see how that goes. Okay, so now I hit process. Oops. And the next thing that it's doing now is just showing me the whole loop. A really important point that I forgot to say before, but it's critical, is you have to have an ECG. If you don't have an ECG for this software, it can't do Speckle analysis. There are packages, particularly for fetal analysis, that where you can do analysis without an ECG. Clearly, you don't have a fetal ECG when you're doing a prenatal scan, but they require you to manually indicate where aortic valve closure is in the beginning of the cardiac cycle. So what it's doing here is it's got the ECG and it thinks it knows where aortic valve closure is. It's put that little green line there, which I think is probably the correct place, but if I wanted to, I could move that. What it's now doing is it's telling me whether it likes if it's able to do this tissue tracking with each of those segments over the cardiac cycle, and it gives me a green tick if it's happy. So as you can see, it color codes all 6 segments in the ventricle, 3 septal ones, basal septum, mid septum, and apical septum, which is the green one, and then 3 free wall segments, apical, lateral, mid-lateral, and basal lateral. It doesn't like that red segment for some reason, I think because it's possibly going out into the epicardium. So I'm going to hit recalculate, and I'm going to just bring that one in a little bit. Let me do that, see if it's happier with that. And then I'll hit process again. No, now for some reason, what's weird there is that it now likes that red segment, but it doesn't like the blue and the yellow. So let me just see if I can help it out there. Be nice if we get them all green. Same problem again. I'm just going to say, look, I'm happy with that. Let's see what it gives us. So I can actually make that, just click on that red cross, make it green, and say, let's just process that and see what it looks like. This is not the most optimal image to be using, but it shows you some of the challenges. So I'm now going to hit approve, and it's generating strain curves for me. So let me just change the scale here so that we can see them all. Okay, so here in our strain curves, the big panel here is the beginning of systole. Then here we've got the end of that cardiac cycle, and we've got aortic valve closure in the middle, which we hope coincides with real aortic valve closure. So we've got systole here and diastole here. And what it's plotting is for each region of the myocardium, each of those color-coded segments, it's plotting the strain or the relative lengthening and shortening during that one cardiac cycle. So let's pick, for example, the green segment here, which is the apical septal segment. You can see that there's during that first phase in systole, the strain is getting more and more negative. So that's representing a longitudinal shortening of that segment during that phase of the cardiac cycle. And then it gets to this point, which appears to be just after aortic valve closure, where we've got peak shortening or the peak systolic strain in that segment, which at this point is about minus 36, which is quite a high strain value. And then from there on, there's a relative lengthening of the myocardium in that region, which gives us a reduction in the negative strain, and the strain starts to become positive here in diastole, and there's a peak positive diastolic strain there. And you can see it does that for each segment. And what we're seeing here is that the peak strain is happening in those apical segments, the green and the purple. The peak strain is higher in those segments, and the peak strain is lower in the basal segments, the yellow and the red ones. And that is a normal pattern to have this gradient of strain, which is highest in the apex and lowest in the base. So that's a normal gradient of longitudinal strain. You can see this dotted white line, that's an average. So that's averaging all of the segments. And the peak negative value of that average is, you can see here, about minus, well, it's about minus 25, if I'm on it there, minus, and the software has actually measured it for us, and that's reporting it, as you see here, as global strain of minus 24.8. So that's the average of all of the segments at their lowest systolic strain. So peak longitudinal systolic strain, and then average to give us a global figure. Now, what you can see here is that the peak appears to be happening after aortic valve closure, and that may well be the case. You often see that in dysfunctional ventricles, that peak strain is generated after aortic valve closure. One of the other things you often see is that the peak strain doesn't always line up. And what you can do is you can measure the time. So if I do this, it should give me you can see in the top right hand corner here, time value comes up from my pointer. So the peak time in that, the time to peak strain in this purple segment, that apical free wall segment, is 189 milliseconds. And that's roughly the same for most of the other segments. But if you look at these two free wall segments, the yellow one and the light blue one, their peak strain is probably happening before that. For the light blue segment, I'm saying about 162 milliseconds, and for the yellow segment, about 126. And you can actually calculate the standard deviation of the time to peak strain as a measure of synchrony, or what's also called mechanical dispersion. And you can imagine that in a ventricle, if the segments are not all reaching peak strain or peak shortening at the same time, that will affect the global ability of that ventricle to be working fully and ejecting as efficiently as it could. So it's not something that's been really well studied in babies. It's something we looked at in the congenital diaphragmatic hernia cohort and saw, compared to controls, quite significant changes in their synchrony. And what's also an interesting question is the effect not just of pathologies on synchrony, but also on therapies on synchrony. So do we have any idea of what different drugs might do to your mechanical synchrony? It pose it as an interesting question, another aspect that we don't even think about. So yeah, that's longitudinal strain. Now, the other thing is we can look at strain rate. So strain rate is not the absolute strain, it's the rate of change of strain. And you'll often hear people saying that when Speckle tracking is being compared to gold standards of myocardial function, and gold standard would normally be conductance catheter measurements, where you put a catheter into the ventricle and you generate pressure volume curves, and you look at specific parameters of the pressure volume curve, usually at end systole, end diastole, as a measure of kind of gold standard measure of myocardial function. And when you do that and compare Speckle tracking indices, including strain and strain rate, to those gold standard measures of myocardial function, it's strain rate that tends to be show better correlation. And in particular, it shows less dependency on loading conditions, on pre and post and pre and after load. So people like strain rate as a measure of, as a less load dependent measure of myocardial function. That said, I find that analysis of strain rate is sometimes a little more difficult. We often get more kind of aberrant, or what look to me like sometimes artifactual values. So in clinical practice, we tend to still report a longitudinal strain rather than a strain rate. But you can see here, you can measure the peak strain rate in each of those segments during systole. And then if you look at diastole, there are two peaks in diastole, an early peak and a late peak. Early peak corresponds to early diastolic relaxation of the myocardium. Late peak corresponds to atrial contraction and that second kind of wave of myocardial displacement. And you can see here that you could measure the strain rate in diastole and report that as a measure of function. And certainly the groups in Dublin, the FIFS group and the groups in Toronto have done that in the past as well. So that's strain and strain rate. Everybody's still with me so far? And we're only looking at the longitudinal plane so far. Any thoughts or questions? Saul, again?
No, I shut up. I'm trying to listen and understand very carefully.
No problem. No problem. Anna's giving me the thumbs up. She's with me hopefully so far as well.
Can I ask a question, Neil? I didn't understand how you moved to the global strain to this to specific ones, to longitudinal, and then you would go to radial.
No problem.
How do you move from one to the other?
Yeah, no problem. If you see where my cursor is at the moment, I'm hovering over longitudinal parameters. So I can go back to velocity, which is, velocity is just looking at the velocity of the myocardium. So in some ways that's analogous to tissue Doppler velocities. I can click on this D for displacement, which is just looking at the displacement of segments. So if you look in particular at the yellow segment here, the red segment here in the basal free wall, that's a bit like looking at the mitral annular systolic excursion. So that's a bit like MAPSI. If we did that in the right ventricle, it would be like TAPSI. Does that make sense? So you can use this analysis, this software to measure those parameters as well. You probably get slightly different numbers from if you're using an M mode or pulse wave to look at those values of displacement or velocity, just because the software is doing it a slightly different way. But then it's S for strain and SR for strain rate. Does that make sense? And there's a little one, show global here. If I untick that, it takes off the dotted line, the average. Make sense to everyone?
Thank you.
What you can also do is you can also, if I go to strain, I can go by mid, endocardial, and epicardial segments. We tend to look at the mid segments. Some people will report endocardial. I would say just go with one, standard value. You can see there's a little bit of difference in the values there, not much. Okay, so we've been looking at longitudinal analysis. Let's look at circumferential, because this is where I think we start to look at the ventricle in new ways that we haven't looked at before. I'm going to hit exit. It will ask me if I want to save that loop. I'll hit yes, just if I've got a nice loop, I always like to save it. Okay, so for circumferential analysis, I'm going to come out of Q analysis again, just so we're looking at our raw loops. Here, we want to look at short axis views here. So just your traditional short axis view. So here is the left ventricle, probably at a kind of mid-ventricular level. I can't quite see the papillary muscles. If we go a little bit lower, that's probably coming onto one of the papillary muscles on the anterior region there. We're coming up the ventricle towards the base, so we're starting to see the mitral valve. And if we go down the ventricle again, back down into mid-cavity, and there's the papillary muscles coming in there. And if we keep going down, this is kind of, sorry, that's looking more at the mitral again. I want to look down a bit further. This is probably coming down more towards the apex. Actually, I think this is probably more towards the apex there. So what I normally do when I'm collecting views for in the short axis now is I'll take one at the level of the mitral valve, one mid-ventricle, usually at the level of papillary muscles, and then one towards the apex. This view is probably not quite as apical as I would like. I tend to often try and go a little bit further down than that, but we'll for the moment, we'll regard that as our kind of apical view. And maybe this one, let me just see if I've got a better one here. That's kind of papillary muscles. Let's choose this as our basal one and see how we get on. It's not a great picture, but we'll see how we go. Okay, so we're going to do Q analysis again, 2D strain, and I'm going to call this short axis mitral valve. So on the select view, it's SAX MV. Okay, it tells me that the size is too small. It's going to revert from a human software analysis to what it calls small animal. Often with small babies, you have to use the small animal thing. It will just default to it. Don't worry about it. So this time what I'm going to do is trace out the inside of the ventricle again. So it starts anterior septum. So I'm going to start, let's start about here. And I'm going to trace around this ventricle. Again, it's not the best 2D loop to be using for this, but we'll give it a try. Once I close the loop, it generates the kind of map or region of interest. I think that's a little bit broad. We're kind of stretching out across the myocardium into the epicardium and across the septum there. So I'm just going to narrow the width of that by clicking on ROI width. That looks a bit better to me. So I'm going to accept that and hit process. The software actually quite likes it. It's giving me green ticks for all of the regions. So I'm going to hit approve. Okay, so now it's generating the curves. Let's start with circumferential strain. So in the bottom options here, I'm going to go to circumferential parameters and hit strain. It's giving me a bit of some crazy curves here, but let's have a look at what we've got. So if we look at the septal regions first in red and in yellow and light blue here, we've got curves that look a little bit like our longitudinal strain curves. During systole, we've got negative values, which represent the kind of circumferential shortening, so the narrowing of the donuts getting smaller during systole. And we can see the peak circumferential strain in each of those segments. The two that are a little bit weird here are the posterior segments in blue and in purple. You can see that the purple one goes negative and then goes positive, and the blue one is kind of always positive. Now, that's a little bit unusual. It could be genuine. You know, this baby was on a lot of inotropes, had possibly had a degree of dysfunction, and this could be genuine. But whenever you see something like that, I would always say, is that real? Maybe let's just rerun this again and double check. So I'm actually going to hit recalculate. I'm going to click new region of interest, and I'm just going to redraw that whole thing again and just rerun it and see if I get the same problem. Let's narrow that down. Oops. It likes it again. I'm not, but when I look, I think what's happening is it's actually coming off the myocardium and picking up the valve there. So I'm going to recalculate that again and just bring these segments out a little bit so that hopefully we don't pick up the valve. And I'm just going to narrow that region of interest. Okay, let's try again. Yeah, I'm still not sure about that. Let's try a bit further out here. Oops, let's do that. Okay, let's try that. Yeah, that looks better. Let's try that. Okay. Circumferential strain. Okay, it's still giving us a similar pattern, so that might be genuine. But you can see that definitely those segments seem to be they don't have a normal negative strain pattern during systole. There's a sort of early peak in that posterior segment, and then it becomes positive again. So it may well be representing a degree of almost kind of opposite motion, and and a lengthening during that segment rather than a shortening of those segments. You can see it's calculated the average again, and that's combining all of those segments. And because those two segments are looking quite abnormal, that's pulling our average back from being more negative to less negative. But we've got a global strain value here of about -19, which is not grossly abnormal. Normal values would be in the kind of mid-20s for a circumferential strain. The other thing we can do is we can look at rotation. So let's look at the rotation here. And again, it's doing it by segment. So what it's looking at here is if it's a positive rotation, remember that's clockwise. If it's a negative rotation, that's counterclockwise. And actually, there's something quite unusual happening here where the three segments appear to be rotating in one direction, whereas three segments are rotating in the opposite direction. So again, that might represent dysfunction in this patient, that we're getting abnormal rotation of individual segments and therefore globally. And you can see the peak rotation is probably quite early in systole here of 3.44 degrees. So let's now look at radial strain. I'm not sure what that's going to look like in this patient. So radial strain is normally a thickening, remember? So we're looking here at the thickness of the ventricular wall in the left ventricle during systole. And because it's thickening or lengthening, it's a positive strain. And you can see in each of the segments here, actually, we are getting a positive strain during systole. We could make the scale a bit smaller to show that a bit more prominently. There we go. And what's odd in this software, and I don't understand why, is that it doesn't give us an average of those segments during when it's showing us radio strain. So you have to kind of measure each of them and calculate the average or estimate it to get the global radio strain from these patients. Okay, what I'm going to do is save that. And so that was circumferential and radio strain in the base of the ventricle. And let's now look at towards the apex. I think we like this one. Yeah, I think let's use this one. Again, perhaps not quite as apical as I'd like it to be. So this is short axis apex, okay? And it's showing us the ventricle at the end, just the frames at the end of systole. So we'll do the same as before. We're going to draw a loop here of the ventricle. It's a little bit odd because we're right at the end of systole, and there's that ventricular cavity, as you can see in this patient, is practically obliterated. I need to recalculate that because I'm not very happy about the way it's measured, done things. That's too broad. Patient's got a little bit of hypertrophy as well, I would say. Oops. There. You know what? I'm going to just recalculate this altogether. Let's start again. I probably didn't put enough points in to track the ventricle nicely, so that's a bit better. I've got more points. Okay, let's process that. Yeah, that looks like it's tracking it a bit better, and the system is happy with it. It's giving me lots of green ticks. We might just be coming off in those red-blue regions anteriorly in the free wall, but let's see what the curves look like before we adjust that again. So here we go. So we've actually got quite nice curves here. Let's start with circumferential strain. So you can see we've got much better traces here, and we've got nice aligned traces. They're all showing a negative circumferential strain, i.e. shortening during systole. It's greatest in that kind of septal posterior region, and then posterior free wall, and then lower in the kind of anterior and posterior segments in the free wall and the septum. And you can see we've got nice alignment of the peaks, so good synchrony, and it's giving us an average or global of -33, which is actually supranormal. Again, this patient was on a lot of inotropes, so that's possibly why. And if we look at rotation, you can see in this region there's good alignment of the segments. They're all showing a positive rotation at this point in time, and the average is about, we're getting 8 degrees. And then in diastole, you can see it's actually a reversal of that, and it should be almost the same, yeah, 8 or 9 degrees. And that makes sense. The ventricle rotates by a certain number of degrees in systole, and then it's got to rotate in the opposite direction during diastole by the same amount. So you should expect symmetry in the rotation there. And then we can also look at the radial parameters. So there's radio strain, positive displacement in all the segments, indicating thickening, and they all line up nicely. And we could look at radial strain rate if we wanted. That's looking a little bit all over the place. You can see systolic and diastolic values. I don't know quite what to make of that. Okay, now at this point, remember we've measured rotation in the base of the heart and in the apex. So the software has recognized that, and it's going to calculate the difference between those two and give us the where are we? Should we twist? So if I go up here, I can now click on twist. So it's remembering what it's doing here is it's showing us the curve that we had from the apex, which is the blue one we've just been looking at. That's the average. And then it's also superimposing the purple one from when we analyzed that basal image of the heart. And it's giving us the difference between the two, which is the blue line. Now, normally we'd expect the basal rotation to be more negative. And that would give us an even bigger value for the difference between the two, the twist. But actually, the twist here is relatively small. It's that apex minus that base, and it's only 4 degrees, and it's positive at that point. So that's how we get a twist value. Because babies' hearts will differ in size depending on their gestation, what's often reported is the torsion, which is the twist divided by the length of the ventricle. So we can report that, so that's normalizing it for the size of the ventricle, reporting it as a torsion. But we'd have to do that manually. The software doesn't do that for us. Great. Okay, guys, I'm going to stop talking there and just really interested in whether that's made sense to you all, and whether it's been interesting. And I think the more important point is not so much that I think everybody should be calculating, longitudinal, circumferential, radial strain in all these babies or strain rate, nor that they should be calculating twist in all these babies, but maybe the starting point is just for us to appreciate that the ventricle's function is much more complex than just measurement at a single point of a single parameter can indicate to us. And as we start to think about this more functional analysis, we're getting a better idea of that global function and dynamics of the ventricle. And sorry, I took a lot longer than I planned to, but
I have a question, Neil. I found that really fascinating, to be honest. I knew about it, but I never did it myself. Yeah. I wonder, do we know the effect of specific drug on specific function in terms of circumferential radial? Because if we identify that this function is radial and, for example, dopamine act on the radial function, that would be even more targeted echocardiography. So do we know anything about that?
I think that is I think that's such an important question, Virginie, and the answer is we don't. There's some data certainly from animal work and from adult work that shows the effect of dobutamine, dopamine, epinephrine on global myocardial function measures. But to my knowledge, there's really, keep me right in case anybody else knows of it, but I've not seen data from neonatal studies, certainly not within preterm or term age groups, showing the different effects of different inotropes and agents on different parts of myocardium. We've tried to study it at different times. We've tried to conduct studies to do that. So going back a few years ago now, but when I was in Melbourne, we had ethics approval for a study where we wanted to look at the effects of dopamine and dobutamine on these myocardial parameters. But it was really hard to recruit because most of the time the patients were started on them before we got a chance to do a pre and post analysis.
Thank you. And the other question, and sorry, then I leave Jay. Jay has a question for you. When we say the neonatal myocardium is immature for preterm, do we know what is immature in the function and how the maturation goes following the 3 different?
There are some nice papers, especially from a FEEDS group in Dublin, looking at rotational dynamics in preterm infants. And there are some normative papers from normal term infants and preterm, well, not preterm, but late preterm infants to give us some normative data for comparison. But it's not something that's used widely enough for us to as yet express it as a normal parameter. I would say it's interesting when our cardiology technicians come and do functional analysis, they'll report global strain for us, but they're only reporting global longitudinal strain. They don't tend to report radial or circumferential. I've certainly not seen twists reported, and I think we're even ourselves, we're just beginning to look at that. Abhijit has done some really nice work looking at it in the CDH patients. Maybe another opportunity can show you that as well. So yeah, I think we're all just getting to grips with it. The other important thing to state is that the different softwares historically have given you different numbers. So whether you were using GE EchoPack or whether you were using TomTech or different manufacturers, Speckle analysis, there's variation. There's manufacturer variation in the values that you get, and so it's important you appreciate that you're in the same patient anyway. You're using the same device and the same software analysis. Sorry, Mahmood and then Mark.
Thanks, Neil. Really fantastic session, as always. I don't know if you agree that probably the circumferential strain is more protected than the other ones and it's not easily affected in like the disease pathologies. I found in particularly like in HIE babies, it's not, if you get longitudinal strain, it's very much affected, whereas the circumferential one, it's sometimes remains unaffected. I don't know if you come across similar cases.
I think that's a really important point, Mahmood, which is the variable effect on the myocardium. And there's, you know, the more I've looked at this, the more I've realized that when I only look in one plane, I can be mistaken in the impact on the patient's function. And I've seen both of those situations, patients who look in the 4-chamber view and the long axis subjectively like they've got pretty impaired function, longitudinal function, and yet circumferential, when you look at the short axis, is actually looks quite nice and preserved, but also vice versa. Seen patients where the 4-chamber view, things don't look too bad, but then you look on the short axis and you can quantify it using the Speckle tracking, and the strain is very abnormal. So for me, I've learned you've got to look in all planes. And I don't know, you know, again, it's an interesting question. Do different disease processes affect function in different ways? And we've certainly seen, even within, you know us, we're obsessed with diaphragms, and that's the group we've looked at the most. But even within that group, you get really quite variable patterns of dysfunction across the groups. And again, Abhijit's data on twist is showing us that as well. We see some patients where they've got a very abnormally low twist, somewhere it's preserved, and somewhere it's supranormal, and we think it's almost like a compensatory mechanism, but they've got very abnormal longitudinal function. So they're all, the more you look into it, sometimes there's more questions rather than answers.
Thanks, Neil.
Neil, there are some questions in the chat by Jay, and yeah, Jay has asked 2 questions if you wish to address them.
Yeah, sure. Jay's question about EchoPack. We use EchoPack on, we've got a dedicated desktop for it. I can't remember what version of Windows is running on there. I could have a quick look in a second for you. But yeah, it's, I suppose, 2 points. EchoPack isn't cheap software. You need a little dongle to activate it, which is actually quite the expensive part of it. And we rely on a pretty good relationship with our GE rep to keep us updated so that it keeps working. And I recognize that not everybody has access to EchoPack. Reassuringly, and I know others will have experience of this, on the S70 machine, we were just demoing it a few weeks ago, and we're hopefully getting one in the next few weeks. That's got a lot of this functional analysis built in on the machine, and Anne-Marie was having a bit more of a experience of that than me when we were demoing it, and it was looking really good. So I think that you don't need EchoPack on the upcoming machines. The software is on there for analysis as long as you've spec'd the machine with it. And Anna's kindly posted the reference there for the maturational patterns of deformation in the first year and preterm infants, which is brilliant. And then there's a question from Jay: do you feel strain pattern in those babies with pulmonary hypertension, diaphragm with pulmonary hypertension, so specific STE patterns in relation to circumferential? Yes. So yeah, we first of all observed in the diaphragms they had reduced longitudinal, circumferential, and radial strain. But then we did another analysis which published where we also looked at the segmental strain, so within each of the regions, and also at the mechanical dispersion or synchrony of the segments. And what we saw was that was quite abnormal although it was globally abnormal, which was interesting. So there was in the diaphragms, we saw that there was in the left ventricle, I talked before about that apical to basal gradient in strain. So the peak strain is greater in the apex than in the base. And when we plotted that in controls and then in CDH, we saw that every segment was kind of proportionately reduced. And that surprised us a little bit, because in the CDH ones at that point, we thought that it would be the septal segments that were more severely affected, because if the right heart was dysfunctional, that would cause the septum to be dysfunctional, and therefore we'd see more dysfunction there. So it was one of the analysis that actually helped us to kind of get our heads around the fact that, okay, maybe there's more primary left ventricular dysfunction in those patients. Great. Sorry, I know others have got to go because I'm talking too much as usual, but Mark's had his hand up. So maybe before I do go, just come back to you, Mark.
Yes, thanks, Neil. Great presentation. I've got two questions, actually. You know, this was on the left ventricle. The right ventricle, as you know, is a more complicated 3D structure.
Yeah.
So the regional differences will be more accentuated and consequently more blunted when you take an average.
Yes.
What do you think of that? That's one.
Yeah.
And number two, you know, with adults, the value of strain is a bit unclear when you've got preserved ejection fraction. Do you ever see this situation where you do a strain analysis, you know, you find it's problematic, but the ejection fraction is still preserved?
Yeah. To be honest, Mark, I'll start with that second question first. To be honest, Mark, I don't look at ejection fraction very often because we got used to looking at these other techniques. But I think, and you might have more, I'd be interested in your experience, you've got more experience of that. And I think it goes back to this idea of, you know, if we're looking only at, if we only use one measure, and that could be, you know, it could be that strain is that one measure, it's still relatively blunt tool. We're still only looking at one aspect of ventricular function. And when we're doing functional analysis, I would argue that we shouldn't, you know, just be using strain, certainly not just global longitudinal strain, because that is a bit of a reductionist view. We should be using multiple parameters and putting those together. And we'll see situations where you get preservation in one but dysfunction in another. And I actually think that's where we're getting, you know, in adult cardiac failure, heart failure, my simplistic understanding is that they talk about patients with heart failure with impaired ejection fraction, i.e. systolic dysfunction. And then they talk about these patients who've got heart failure, but with normal ejection fraction. And my view is, well, why, you know, to me, it's kind of such a weird way of defining heart failure. Clearly that patient's ventricle isn't working. It's just that the dysfunction is happening either in terms of its timing or its nature or its regional aspects in a way that ejection fraction isn't the right measure for it. So you've got to, you know, look at other ways in looking at the ventricle. I mean, I understand why people classify things in that way. We all want this simple, you know, single measurement that will tell us everything we want to know. You know, it's like the grand unified theory of everything. Yeah. But clearly the heart, you know, pushes back against our reductionist view and wants us to look at, you know, in all of its different aspects of function. And what we're seeing when we're doing that is that we can get fooled, like Mahmoud said, it can look normal in one plane, but it's clearly very abnormal in another. And it may be that, you know, twist, if we start to use it more, becomes a much more valuable aspect. You know, like I said at the beginning, we think twist contributes to 60% of that ventricular function and ejection. So maybe there's been a huge black hole in our analysis of these hearts when we've not been looking at it. And just to go back to your first question about analysis of the right ventricle, I mean, I didn't even get around to showing you strain on the right ventricle. Even when we use Speckle tracking on the right ventricle, it's hugely flawed. Firstly, we're using the software that was designed in adult left ventricles and we're applying it to neonatal right ventricles. So, you know, we're already, you know, trying to apply something that was never developed for that purpose, and we do it. Secondly, as you say, the right ventricle's nature of function there is so much more complex that it's an oversimplification just to look at one direction. But I do find longitudinal, I don't look at circumferential or radial function in the right ventricle just because I think that's, you know, it's just not possible with the software we're using. It's designed for the left, not for the right. I think you can convince yourself that maybe you're getting something meaningful from looking at right ventricular longitudinal strain using that software, even though it wasn't designed for it. Firstly, because the right ventricle has quite a lot of its function in that longitudinal direction, but also because the morphology, I suppose, allows us to convince ourselves that we are looking at it appropriate its function there. And our data looking at right ventricle when we have done it in the diaphragms has shown us some differences that we suspect are real between normal and controls. But Mark, I'd be really keen to hear more about your experience of looking at right ventricular function. I know you've done a huge amount of work on that.
Thank you.
And honestly,
nice
I think if we can dedicate at least one of these sessions to hearing more about your work, that would be great.
Thank you so much. Thank you. Great presentation, Neil.
Thanks, Mark. Okay, guys, I'll stop talking there because otherwise I'll talk all afternoon. But thanks for listening. And yeah, I hope I haven't created more confusion. Really happy to show you that analysis more, particularly in relation to some interesting cases in the future.
Well, Neil, do you still have some time? I have a very basic question, if you don't mind.
Yeah, no problem.
So I've always felt and found Speckle tracking tracing very subjective to the skill of the operator. So if you have an image, a video clip of 4-chamber, which is not of good quality, it'll be the software will keep rejecting your Speckle. Does it matter, and how far does it matter? So, for example, please pardon me for saying this. I thought the image or the 4-chamber view you showed today. I'm sure you have many more.
It's not a very good. It wasn't a very good view. It wasn't a very good view. Yeah. You don't have to. You don't have to flatter me, Ahmad. It was a pretty terrible picture for analysis. The reason I chose it was just we're in a bit of a rush, and it was the most recent one that I could remember. But and the reality is, it also highlights the how you want to get kind of optimized views to do this analysis on. We've tried to do quite a lot of retrospective analysis of Speckle tracking, and from that we learned a lot about the importance of the quality of the images. I would say that one that we did today was acceptable, but not optimized by any means. And you want to try and get as much as possible a really nice view, ensure that the apex for the LV and the RV is fully visible, and the views that I showed you, particularly the circumferential view at the base, was pretty suboptimal. So yeah, don't do what I do, get better images, and then you'll get even nicer analysis.
Okay, great. Yeah. So thank you very much. Yeah, your talk today is absolutely worth seeing a few times. I'll be seeing it a couple of times after this. Yeah, so thank you very much for the talk.
Thanks, Ahmad. No problem. Thanks very much, everyone. Good to see you all. Have a good weekend.
So I think there are no further questions, so we can thank you and break off then. Okay, that's it. Thank you, Neil, again, and
thanks everyone.
Thank you.
See you later. Bye now.